Perfect.
All right, and there we go. Hello, everyone. My name is Kyle Capone. I am a PA in thoracic surgery, and I'm also the director of education for ASPA. And I am very proud and very happy to introduce Mr. Jerry Simmons today, who is a surgical PA with more than 25 years of experience and nearly as long as a leader in ASPA. He has been an ASPA president twice and is currently the chief delegate to the AAPA. He is an award-winning international CME speaker on surgical and GI topics and is currently an assistant professor at Stony Brook University. He has received the Kirkland Award for Excellence in Surgical PA Teaching, a practice, and more with, I'm sorry, surgical PA practice, and more than 15 awards for teaching. He began in vascular surgery, and with the rise of endovascular surgery, led to training in GI surgeries of all types. He has a special interest in reducing post-cholecystectomy, diarrhea, and GI complaints, and minimizing changes to the gut microbiome after bowel resection. And we are all very excited to hear his talk tonight on appendicitis, and I will hand it off to Jerry.
Great. Fantastic, Kyle. Thanks for that intro, and to you and Michelle for setting this up, and all of you ASPA members out there listening tonight, and all of you listening out there in the future. So I know. You're like, the appendix, like that's so boring. You know what I mean? But everybody, the appendix in the world of general surgery has really become a super hot topic. Not only is it very, very common, right? If you're in general surgery, how many times are you doing an appendix in a week? It's the most common surgery out there, right? And, there's that big debate between what is the best treatment of appendicitis. Is it something medical? Is it something surgical? We're going to get all in on that. And when I tell a good appendix story, one of the most famous stories out there is not like Harry Houdini, the magician, his appendix killed him, or Walter Reed, who died of appendicitis. One of the most amazing stories is Elton John. And you may not realize that he literally had a near death septic experience from what started off as a simple appendicitis and developed into something a lot more deadly. In fact, he actually said in several news interviews that he felt he was lucky to be alive after dealing with a ticking time bomb of appendicitis. And I know what you're thinking, like, it's modern day. Like, who would ever have a big problem from a simple appendix? But this was a huge story we're going to get into and go into what we're seeing nowadays, right now. So he really had like a near death experience. It was prolonged. He was misdiagnosed. He had several dangerous complications, which we're going to um, get into. Because think about this, this is a guy that could afford any doctor, any test, any clinic. And with all of his resources, nobody could figure out that he had an appendix that was flaring up. So we're going to really look at what happened to him then. And as many of you people in general surgery know, in December 2025, like, the world temporarily stopped spinning. It was a major event in the world of general surgery when the updated World Society guidelines of appendicitis actually came out. So we're going to deconstruct what came out last year in December 2025 and how it might have affected what happened with Elton John. Elton John's appendix was not minor, right? It was prolonged and misdiagnosed, right? He's lucky to be alive. And again, as Kyle said, my name's Jerry Simons. I've been on the ASPA board in one way or another for years and years and years. I work clinically, mostly outpatient surgery center now. I teach at the Stony Brook PA program. And through ASPA, one of the things I'm most proud of, besides ASPA spearheading the Advanced Trauma Life Support certification for PAs, which never existed. When we took ATLS, we used to get a thank you letter, but through ASPA now we get certification. But it was really back basically like in the late 90s where we came up with the whole idea of a pre-PA training program and training sessions and pre-PA membership and tracked. So all of you pre-PAs out there or who were a pre-PA at one time, there's a little bit of ASPA in all of you out there. Really interesting. So everybody, Elton John developed appendicitis when he was 66 years old. That's a red flag right there because, as you know, like that is not a normal time for appendicitis to happen. He was much older than your typical appendicitis patient. He was on his major European concert tour, part of his $1 million experience. He was in Hyde Park in London. He had major outdoor shows, lots of charity events, and during his tour, he started getting stomach aches, weakness, fatigue. He couldn't eat. He didn't feel like eating. Every day, the pain was increasing over time. And in his story about this, he said that he played 10 full concerts really in severe agony, each concert getting more and more pain. He tried all the over the counter gut remedies. He tried just liquids, not eating at all, and nothing was helping, right? He had unlimited access to medical resources and he just kept getting sicker and sicker with abdominal pain, inability to eat, weakness, flu like fatigue, things like that. And only after looking at this, when the situation was resolved, he realized that he'd been brewing a major medical emergency for weeks, right? So, all through June of 2023, he's nauseous, he's got stomach aches, he's getting flu like and febrile until in Germany, he walked off the stage. If you look at the video, he's actually splinting himself. And he decided to go back to the UK for evaluation, where after 2 weeks of agony, it was found that he had an appendiceal abscess with retrocecal appendicitis. In retrospect, that retrocecal appendix, behind the cecum, is probably what walled this off and saved him from becoming septic really early on. Of course, with a situation like this, even in 2026, we're not doing an immediate appendectomy. So, what they did after his 2 weeks of severe pain and suffering, they, of course, put in a drain, gave him IV, and then converted him to oral antibiotics. And he started feeling a little bit better. He's like, okay, millions of people have paid to see Elton John. I better get back on there. He only had with a drain, so now he's running around on a tour with drains and antibiotics. He had a very brief window of improvement, but then he started getting much more pain, very high fever, tachypnea, dehydration, that scary flu-like malaise that we see SIRS patients developing. You know what I'm talking about, right? So he started getting septic. He was in Monaco. He went to the closest place, which was the Princess Grace Hospital in Monaco, where he underwent an urgent appendectomy, right? He ended up having to cancel all of his remaining tours. And as we said, he felt like he was lucky to be alive. He was so grateful that he was able to survive this. So, everybody, all through June, he's getting sicker and sicker. He's not eating, he's getting increased abdominal pain. Looking at his CT scan, he had a retrocecal appendix. That appendix wasn't hanging down inferiorly, it was tucked in behind his cecum. And all of the data shows that walling off that retrocecal appendix is what saved him from having a major perforation with severe peritonitis and earlier sepsis. You know that true retrocecal appendix is pretty rare. Only about 16% of the times are we actually seeing that. Now, this developed into an appendiceal abscess. And as we said, the abdomen was just too hostile for him to be able to have any surgery done when he flew from Germany back to the UK. But what ended up happening in Monaco is that the drain, the antibiotics just didn't work. He had that acute onset of pain. His appendix ruptured even after all of this. He developed peritonitis. And at Princess Grace Hospital, he ended up needing that emergency appendectomy. So, everybody, what is bonkers about this is a guy that had every doctor, every resource, unlimited means to figure out his abdominal pain, and nobody was really able to figure it out. So that is what makes this story so crazy. Everybody, even more crazy, about 2 weeks later, Anderson Cooper, then of CNN, in the middle of Manhattan, had a very similar situation. He had an undiagnosed appendectomy, literally a few weeks after Elton John just barely survived his. Now, back then, we used something called the Alvarado scoring system, right? It's in Epic, and this is a classic appendicitis scoring system where, of course, the higher the point number, the greater we're thinking about appendicitis, right? He talked about migrating pain. He couldn't eat. He had nausea. He had abdominal pain. They didn't document, at least while he was touring, what his temperature was, um, or if he had rebound pain. And everybody, I dream at night, close my eyes, wrap myself out up. I'm like, what if early on someone just did a psoas or an obturator or a Rovsing, did some kind of basic physical exam on Elton John? Because you know that retrocecal appendix is psoas and obturator. That's what's going to show up, not necessarily just hitting on McBurney's point that way. Now, I know. You're like, Jerry, you do have a lot of gray hair talking about Alvarado, but Alvarado was what was used back then. Now in 2026, we're using AIS, AAS, the appendicitis inflammatory response score, the adult appendicitis score, and a different score for peds, right? The beauty of using these scoring systems is it standardizes this debate about appendicitis, giving us guidance and classifying appendix as a low risk, intermediate, or high risk. Everybody, in the year 2026, if you're dealing with appendicitis, you need to be using one of these three scores: low risk appendicitis, intermediate, or high risk. And I think with the right data, if we use the adult appendicitis score, that Elton John would have scored much higher than Alvarado, and they probably would have figured out his emergency much earlier, right? So these are the scores. If you're a general surgery person, you're probably using one of these or something similar. I know. In reality, very often you're going to figure out that they have appendicitis and you're going to click this after the appendix is out in Epic, but these are still standard scores. We're pushing for them to be used in the ER, in surgery, things like that. Wow. That's a really exciting Anderson Cooper and Elton John, right? And those are some examples of why appendicitis in 2026 still matters. Everybody, like I said in the beginning, appendicitis is the most common surgical emergency. If you're a general surgery person out there, we see this a lot. New data that just came out in December 2025 showed that about 12% of men and almost a quarter of women will have an appendectomy in their lifetime. So we do a lot of these. It typically peaks around age 10 to age 30. So those younger and much older have an atypical presentation and they have a much higher risk of perforation, right? younger and older adults, because they don't always follow that classic presentation. You already remember that the appendix is not static. It can freely move around below that cecum. And an appendix more in the front, you're going to have anterior pain, McBurney's point, rebound. An appendix more inferiorly, you may have less symptoms. Retrocecally, you may have more of that psoas obturator, things of that nature, right? And there are so many variations in diagnosis, management. Do you do ultrasound? Do you do CT? Do you not need an image at all? So, as I said, these new guidelines that came out December 2025 is a big deal. It literally, like, I felt the earth stop moving when these guidelines were published. You need to be using these guidelines if you're a general surgery person treating appendicitis. We're going to get into them, right? So not only is appendicitis the most common surgical condition we see, it's also the most commonly performed emergency operation. And I encourage you to always consider appendicitis in anybody with abdominal pain, right? Even that person that's had a scar, did they really have their appendix out, right? So you always want to consider that, even if they claim to have had an appendectomy. And just like Elton John, leaving an appendix untreated could be a big problem. Everybody, if you're taking notes, the big buzzword that I need you to remember is perforation of the appendix can cause infertility in women. Like, I firmly believe they teach that one fact to lawyers, right? Now, you know, when you look at this number, 12% of men have an appendectomy and about 25% of women. Because everybody, if we have someone that fits the picture of appendicitis and she's of childbearing age, we have a much lower threshold of doing that appendectomy early. Because if it does perforate and she becomes infertile, then that's not good for the patient, right? That's going to be a big problem. Now, all of you know that appendix is a blind, tube at the end of the cecum. It can be 6 to 9 centimeters. The tip is fixed, but again, it can rotate around. Pelvic, pre-ileal, post-ileal, ileal, subsequal. So that position is going to affect the exam and the symptoms, right? What's interesting is that appendicular artery, which comes from the superior mesenteric, is an end artery. So it's susceptible to ischemia, right? The appendix is not like the hand where you have two arteries flowing into it. If that appendicular artery gets obstructed from swelling in the area, that's going to start causing ischemia, right? It drains to ileocolic nodes and ileocolic vein. So that kind of end artery, if there's any students out there, that end artery concept is going to be key. This is a great picture. Remember that the Taenia coli always lead to the appendix. So if you can't find it, look for that Taenia coli, follow it down to the cecum. It'll always lead you to the appendix, right? So appendicitis, we know already, right? It's inflammation of the appendix. The appendix is blocked from a little fecalith, from lymphoid hyperplasia, like local inflammation. You can see this with Crohn's disease. And also, believe it or not, irritable bowel syndrome has an increased risk of appendicitis. That concept of visceral hypersensitivity and inflammation is huge. Yes, Crohn's disease. One of the ways you'll know is they have a high C-reactive protein, an inflammatory marker, and they have a low immunoglobulin A. That's that marker of the health of that gut mucosa. Those are risk factors in both Crohn's and IBS for appendicitis problems. It indicates a lot of other problems too, right? But this blockage, this fecal impaction, this fecalith, this lymphoid hyperplasia is what compromises that blood flow, that artery, and starts leading to tissue death and rupture. And all of those bowel contents from the cecum will start spilling out all over. And again, like we said, people have died from a perforated appendicitis, right? Now, the problem is, everybody, once you have a fecalith in the orifice of the appendix, the rest of the appendix doesn't realize that there's a blockage. The lining of the appendix keeps producing mucus. That mucus being made in the appendix keeps increasing intraluminal pressure to the point where you get so much pressure that you can't perfuse your capillaries. You can't get venous and lymph blood out. And that pressure, that vascular compromise triggers the epithelial breakdown, that bacterial translocation, and all of this is leading to that perforation. Yeah, gut bacterial translocation is a big deal. Speaking of how that appendix likes to move around, some men with retrocecal or retroileal appendicitis will actually hit the ureter posteriorly, and they present with just testicular pain. They might have a vague abdominal pain, right? Testicular pain. They don't want to eat. Remember, poor appetite, at least in my experience, is a classic buzzword for appendicitis, right? If that appendix, that 6 centimeter, like is long enough to get into the pelvis, you could get bladder, suprapubic pain, pain with urination. Even I remember one person, they had it posteriorly. They felt like they had to have a bowel movement, but nothing ever came out. So remember, this appendix is going to vary in its location and vary um, in its presentation, right? Most of you remember with acute appendicitis, they have epigastric pain, which radiates to the right lower quadrant. Remember, a retrocecal appendix will not do that. They may just have back pain, and so has an obturator. And pregnant women don't follow epigastric to McBurney's point rule either, right? Now, when you think about T10, that is the innervation of the appendix. That early inflammation of the appendix is going to give you pain in that dermatome. Yeah, you know where I'm going with this. That's that visceral pain, that epigastric pain. It's periumbilical, it's poorly localized, things are being stretched. That viscous, that hollow viscous is being distended, right? This early visceral pain, you can't localize it. You have a lot of cramping and burning, right? So this visceral pain is coming from that distension, the mucosa, the muscularis, that hollow viscera being dilated, visceral pain. As it progresses, it starts to shift to more localized somatic pain. Like, so that is it, right? You have epigastric pain, and then like, boom, it radiates right to a point, and the patient's like, it hurts right here, and they're pointing right at McBurney's point. Everybody, if you're taking notes, write that down. I don't get scared very easily, but I'm going to freely admit to you, when I have a patient with abdominal pain and they are very visceral, I've got a vague, achy, visceral pain. If I come back doing a serial exam and they have become somatic, they're like, Jerry, I had pain all over, but now I have pain just in that right lower quadrant or just in the, left upper quadrant. Like it goes from vague to a very specific area. That means their pathology is progressing, right? A transition from visceral to somatic shows that this underlying process is moving. Now, sometimes we deal with people with long-term chronic pain, like they come in every month with abdominal pain. They'll very rarely present as being somatic, right? If a chronic abdominal pain patient does become somatic, they should get laparoscopy or usually find an adhesion or something like that. Now, as we said, with all of this going on, appendicitis can kill people, right? Now, everybody, I started my surgical PA career in the middle 90s. We started doing laparoscopic appendectomy in the 1980s. Everybody, look at this picture and follow the arrow. In the 80s and early 90s, our staplers were not that accurate. Everybody, look at the arrow. See this little blue stump? In the 80s and early 90s, with that tech that we did back then, people could have a 1.5, I've even seen a 2 centimeter stump appendicitis. What I'm telling you is true. Listen to this. In the 90s, I had a patient like, oh, I had my appendix out in 1988, and they did it that new way with the little cameras, right? I'm like, listen, mister, they didn't get all your appendix. You have appendicitis again. We got to go in there and get that stump appendix out. I've seen a couple of those, not as many now in 2026. Late 90s, 2000s, that was the thing. You know what I mean? One of the things we do know with all of this inflammation is make sure you measure a C-reactive protein. It's going to tell you how inflamed the appendix is. It's also key for our appendicitis scores that we were looking at previously. Just remember, kidney failure, their CRP is like never what we expect it to be. So, what if Elton John, we actually looked at some of these signs and symptoms, right? That abdominal pain localizing to the right lower quadrant, anorexia. I said once or twice before, in all my experience, I have never really seen a true acute appendicitis where they had anorexia, where they didn't want to eat, right? So all of my appendicitis people have really no appetite. Nausea, vomiting, low-grade fever, and a high white count, right? So everybody, what's really interesting is even with POCUS, ultrasound, CT, laparoscopy, do you know over the last 15 years, even with all of our new cool tech, the rate of misdiagnosis has remained about 15%. Those are the people that typically include appendiceal rupture. And we do know the percent of misdiagnosis cases of appendicitis is higher in women than men, right? Which we're trying to work on that, right? We don't want women getting a perforated appendix and becoming infertile. The other thing to remember is the average appendix has up to 14 different organisms during perforation. So, your cephalexin, that first generation cephalosporin, may not always cover this. We're using a lot of carbapenem, sometimes even metronidazole, right? Typically, E. coli and Bacfrage are what you all know to expect. So we kind of went through this with the whole story of Elton John. How are we diagnosing appendicitis? Of course, with the history, right? Abdominal pain. Half to 2/3 have that classic epigastric radiating to the right lower quadrant, right? That's a classic presentation. Everybody, really important. If you're getting tired, wake up. Important. Write this down. Someone comes in with appendicitis, you need to figure out as best you can when it started, right? Look at this important fact. The blood supply is impaired at about 12 hours, and perforation and gangrene starts to occur at 24 hours. So everybody, this is huge for you when you're doing an ER consult. If the ERPA is like, Jerry, I've got an appendix for you. You go down there and you're like, okay, lady, how long have you been sick? I know you've had some vague middle pain and now you have some right lower quadrant pain. When did this start? And she looks at her Apple Watch and she's like, oh, it started about 6, 7 hours ago. It really hurts, right? So everybody, you have a bit of a window to figure that lady out. But please listen to this. If the patient is like, oh, it happened last night, this pain has been getting really bad 10, 11 hours, right? Everybody, that magic window, that 12-hour where blood supply starts to become impaired, that's a red alert. The closer you get to that 12 hours, the more aggressive you become. One of the things we know is that getting antibiotics going is going to stop the clock. That's right. Check it out. You get an antibiotic going, you make them NPO, you're giving them fluid, you start antibiotics, you get that IV antibiotic going, you're going to stop the clock and save them from a perforation, right? If it's over 12 hours, you're getting much more aggressive with these people. Everyone, you're going to get to watch this on the ASPA website. Watch it over and over and over. Remember this slide. Take a quick picture. These numbers are key, right? Now, one of the ways we know, especially if you're over this 12 or 24-hour window, that perforation is coming is obviously they're having rebound and peritoneal signs, and it starts spreading. Spreading rebound, always makes a surgical PA nervous. When you look at the reports from Elton John, this is exactly what happened, right? He had rebound tenderness and it started to affect the whole abdomen. Physical exam really depends on how long they've been sick. You know that there is a lot of omentum in that right lower quadrant. And everybody, I see this a couple times a year. A patient has classic appendicitis, epigastric pain, right lower quadrant pain. They're in the ER. They call for me. They're like, Jerry, I have an appendix for you to see on bed 5. I go down there. I grab the curtain. I pull the curtain away and I see the patient getting dressed. I'm like, I'm here. I'm the surgery guy. I'm here to see you. They're like, oh, I feel much better now. I think I should go home. Everybody, this is a well-known phenomena that the inflammation of the appendix will pull some of that omentum to the right lower quadrant. That omentum will wrap around the appendix and basically mitigate their symptoms. Many of these people are like, oh, I'm sorry I came in. I'm feeling better now, right? This is going to obscure ultrasound and sometimes CT. So this is another big red flag. If they have all of those signs and symptoms, keep your alert up. So these patients, I remember pulling the curtain around and they're getting dressed. Oh, I feel better now, right? Yeah, if I let you go home, you're going to perforate, right? Remember, McBurney's psoas obturator, we do this stuff every day. So as I said a few minutes ago, remember this slide, right? Appendicitis is abdominal pain, anorexia, nausea, right lower quadrant pain, low-grade fever, and a white count, right? We know that that white count is 70 to 90% sensitive. It's not that specific. Everybody, there's this ER, you know, rumor that you can't call surgery for an appendicitis because the surgery people are always going to want to know what the white count is. Like, it's not that true. Like, it's like an ER legend. Be afraid of calling the surgery team for appendicitis without a white count, right? It is useful, but we're much more focused on all of the symptom progression. And if you had to pick one thing, people, get the C-reactive protein. It's critical for all of these new checklists, right? We like to start with point of care ultrasound. You probably have one right in your pocket. You take a look that way. CT, unless they're little kids or pregnant, we're going to do ultrasound, right? Really hot, swollen appendix, you're going to be able to see up, you're going to be able to kind of see that donut shape as long as you're getting that angle correctly, even longitudinally. You'll be able to document that. For many people with all the classic symptoms, that's enough. This was a really great study, right? Where you look at white blood cell count and ultrasound compared to the rate of diagnosis of appendicitis. And they have all the classic symptoms, right? White blood cell count, negative, ultrasound, negative, right? Still, 53% of them were having appendicitis. Look at this. This is what surgery people or ER people too get excited about, right? Look at this, right? White blood cell positive, ultrasound negative with all the classic symptoms. 74% appendicitis, right? Very similar. So we're looking at either ultrasound or white count, right? And if they're both positive, you're running at 92%. This is a good screensaver on your phone if you need a new screensaver. This is powerful stuff. One of the things, on CT that we'll classically look for, where that appendix basically it's getting so big, fat and swollen, it starts getting bent, right? You've heard radiologists talk about that kind of classic arrowhead sign, 100% specificity. If you see air in the right lower quadrant or a sentinel loop, a little kink of bowel, right? Or you just see a lot of hostile drama down there. Extraluminal air is in patients with these symptoms, 100% specific, obviously, for appendicitis, right? So, how do we diagnose appendicitis, right? We are we have our history. 12 hours, 24 hours, very important. We have all our classic physical exam. We have our blood work. We have our imaging. And we're going to put all of this into our clinical risk score, right? Patients typically with very low risk, they have unimpressive symptoms. They have a normal ultrasound, normal CT, normal C-reactive protein. That's the number to look at. You may not need to push them too hard, like to get into the CT scanner. But we know even in 2026, a low dose CT is the gold standard for diagnosis, right? Ultrasound is first line in kids, ultrasound is first line in pregnancy. But if you're not sure, ultrasound, you might have to do MRI. I don't see that often, right? Please remember, if you've got that big fat swollen appendix with omental wrapping, you might miss it, right? You may never see a retrocecal appendicitis, right? If there is a small perforation, that huge appendix is going to collapse down into a pencil size and you may never see it, right? Which is why if we're really have a high rate suspicion, we're thinking CT, right? You also remember your radiologist loves to call out that they see fat stranding and correlate clinically. So if you ever see those buzzwords in a classic patient, that also works for that. Wow, everybody, really exciting. We went through some stories, some pathophysio, the history, the physical, what labs you're going to order. You've written down a couple of important notes. We'll go over treatment and management before we wrap it up. Everybody, if you're taking notes, write this down. In the year 2026, ASPA is here to tell you that the standard treatment of appendicitis is appendectomy. You heard me. I said it. This is being recorded. ASPA is here to tell you in 2026 that appendectomy is the standard treatment, right? Everybody is talking about NOTA, non-operative treatment of appendicitis. Everybody. You have Coke, Pepsi, Mets, Yankees here in New York, Democrat, Republican, all of these big debates, like umbilical hernias. Do you spare it? Do you repair it? Do you do Varese or Hassan? There's so many big debates we have at work. This is a debate. Who gets medical treatment? Who gets surgical treatment? Very important. You need to know. Lawyers know this. Google knows it. Open evidence knows. Appendectomy is the standard treatment. In very select, uncomplicated cases, which we'll talk about, you can do NOTA, non-operative treatment of appendicitis. On the opposite extreme, like Elton John, really severe, complicated diseases, presentations may require drainage and delayed surgery. Everybody, when you're in the ER managing an appendicitis patient, please get them completely undressed and in a gown, right? Again, I don't get upset that often, but if somebody calls for a surgical consult, I've gone down to the ER and they have coveralls on, like carpenters with coveralls. They have underwear and pants on. And I'm like, get that person in a gown. And very important to always document that you did an undressed physical exam, right? Patients who are, of course, should be NPO. Only in really rare cases of severe nausea, vomiting, retching might we put an NG tube in, but making them NPO will usually do it. Give these people IV fluids early. Abdominal pain people are always dehydrated. Start lactated ringers, right? Like we said, antibiotics. Are you going the carbapenem route, metronidazole, first generation cephalosporin? Remember, antibiotics will stop the progression of appendicitis. Everybody, how many people are afraid of the surgical PA or the surgeon? They think we're monsters. We're not. We're nice people, right? One of the ways that I like to be nice is all of these patients, I'm going to give them an H2 blocker. I'm going to give them some IV fumotamide, some Pepsid. It just kind of calms the whole abdomen down. Everybody, next time you're dealing with an ER abdominal pain, give them a little bit of Pepsid, right? Give them pain control, right? As long as their kidneys are good, Ketorolac is a good start. And do those symptom progression. Remember the rallying cry. They're visceral and they become very somatic, right? Now, everybody, in the Cold War, back in the late 70s and 80s, there's a lot of data from the US Navy about, nuclear submarines on patrol. People got appendicitis. But the corpsmen were not trained to do an appendectomy, and they were not allowed to surface to get medical aid. All they could do is give them antibiotics with the thinking that is that appendix kind of like one of these big, ugly diverticulum here, right? We also know that IV antibiotics stop that inflammatory progression, right? And in this data, they actually did report that, sailors with appendicitis that took antibiotics, many of them did get over it. There were some disasters, but many of them did get over it, right? So part of this landmark discussion that we talked about that happened in December of 2025, where they found that antibiotics are an acceptable alternative in very select low risk adults and children. Low C-reactive protein, unimpressive physical exam, not too young, not too old, right? So you will see patients with appendicitis being given antibiotics, right? If they have these very low risk component. Now, everybody, that landmark December study in January, JAMA published antibiotic therapy for uncomplicated appendicitis. This study that I pictured here, antibiotic therapy, this was the original study that got NOTA's attention, non-operative treatment of appendicitis. And here is the much anticipated 10-year follow-up, right? What they found is in adults with uncomplicated appendicitis, 44% ended up needing their appendix out. About, 60% didn't end up needing it. Complications were lower, quality of life were similar, right? So we know now over this 10 years of data that antibiotics are a valid first line option. They don't say it's the only treatment, first line option for CT proven uncomplicated appendicitis. It's a simple patient without comorbidities. C-reactive protein is calm. Like there's no severe fever, SIRS, there's no abscess, anything like that, right? So the big debate now, right? I'm rubbing my eye because we debate this several times a week. What do we consider uncomplicated or not, right? And it's really like that simple college kid, perfectly healthy, comes in, anorexia, right lower quadrant pain, the appendix is a little inflamed, and that's it. Very unimpressive kind of thing, right? Now, when you look at um, another risk that we worry about, and this was literally just published like a couple days ago. I just saw this morning and added it on. People were like, in older patients, are we going to be missing actually cancers, colon and appendiceal cancers that might be presenting as might be presenting as appendicitis, right? So this study asked, would skipping an appendectomy miss potential cancers, right? And what they looked at is, other components of high risk. Anybody over the age of 60 is high risk. Anybody sick for 2 weeks. Anybody with an appendiceal diameter over 1.5 centimeters, that's pretty big. Anybody with perforation, abscess, phlegmon, any suspicious lymph nodes. These are all red flags. So, everybody, the message from these three studies I've shown you is we are using IV antibiotics in the ER, giving them a prescription for oral with a 48-hour follow-up in these very, very simple, unimpressive, uncomplicated appendicitis. And we're not missing a lot of cancers that way. So everybody, that's one of our big messages is in very simple. They have a very low score, the inflammatory score. They have a very low score, low risk. We can give antibiotics with the option for follow-up. Again, in all of my experience, that is still a minority of cases. Non-operative treatment of appendicitis is still a small amount of cases. So tonight, when you go to bed and you're brushing your teeth, I want you to sing this song with me. The song I sing is called No to Not, No to Not, No to Not, Not, Not. Non-operative treatment of appendicitis, no. Appendectomy is still the standard of care, except for these really simple classic cases. So I'm just going to go over a couple of the appendicitis procedures and then we'll wrap it up. This is our classic laparoscopic appendectomy. We're really leaving no stump. Typically, it's done in the Trendelenburg position, helps to facilitate exposure that way, right? Laparoscopic appendectomy is the standard of care. Unless it's a severe complication, you would start with suction. We're not lavaging anymore, people. Lavaging just moves infection all over the place. If you can find any other reason why you're in there, we will do an appendectomy if we're not finding any other pathology, like a Meckel's diverticulum or anything like that. If you do have a complicated case of an abscess, right, you want to get that appendix out in younger people. In older people, not necessarily as aggressive. And you'll do that interval appendectomy later on once they settle down. So, appendix, right? It's our most common procedure. 1735 was the first documented appendectomy. It was done as actually part of a hernia operation. In the old days, they called appendicitis iliac passion, like because he had such severe pain in that right lower quadrant. Dr. Fitz of Boston in 1886 first created that link between appendix inflammation and this idea of iliac passion. This guy is credited with the term appendicitis. And Matterstock was doing similar work in Europe about this time. And Dr. Morton, maybe he's related to the salt company, did the first successful appendectomy. And Kurt Sem, you know that name, 1981 did the first laparoscopic one. Everybody, to make this even more interesting, this happened in Germany. You can imagine a couple of surgeons sitting around in 2016 and they're doing appendicitis, and a surgeon is saying, you know, people have a rectum, people have a mouth, people have a vagina. Why are we still cutting into patients barbarically? What if we do natural orifice appendectomy? Go through the vagina, go through the um, anus rectum, through the cecum that way, right? So, way back then, people still talk about this article. Notes natural orifice, transluminal endoscopic surgery using a natural orifice, right? They've documented that the transvaginal technique is equal time, equal amount of conversion rate, and it's a scarless surgery, right? You're no abdominal scars at all. This was the first big article, natural orifice transluminal surgery, right? They typically go transvaginally, right? And based on the situation, they might have to put a camera in anteriorly, but most of them were all done transvaginally. But of course, it's 2026. The hot debate is, why are we not doing more robotic laparoscopic compared to laparoscopy? And this was just published again in December. Like I said, people, there's a lot of exciting stuff going on in the world of appendicitis, right? Now, we know that robotic appendectomies are still rare. In fact, the American College of Surgeons NSQIP Quality Safety Program, only 50 robotic appendectomies were done of 50,000, right? That's how rare it still is in 2026, right? So it's happening more and more, but slowly. There is, some data on the complication rate, right? Um, Robotically, how would that handle more inflammation? We know that irrigation tends to spread infection around more. If they have an abscess, that would just be drained before doing anything surgically um, that way. So they did do studies in robotic appendectomy, and they found that they had shorter hospital stays, zero readmission rate. And everybody, I know you're getting tired, but listen to this fact. Robotic appendectomy, according to the College of Surgeons data, December 2025, had zero conversion to open. Wow. But you know what? The surgeon that did the most had the best outcome, right? So you want someone that's doing robotic appendectomy like all the time. Experience is key for this. Really interesting, right? Operative time is always lower, but patients got out 14 hours earlier than laparoscopic or even open. So it's coming. Robotic appendectomy, it's coming, it's coming, it's coming, right? So again, just to summarize that, appendectomy is still the standard of care, right? They're NPO, they're being given IV fluids, you're giving them antibiotics early, 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 early. In laparoscopy, we're typically going to be doing, at least three trocars. Some will put in fourth, especially where we're going to put the extraction tube in. And we're starting, of course, at that umbilicus. That's where our camera is going to go in. We have a suprapubic camera as well to really be able to sweep the abdomen to look for any other issues that way. You're exposing the appendix laparoscopically. You got to go for that artery first, right? You got to dissect that mesoappendix, making sure that you don't disrupt that appendix. It's going to be swollen, inflamed, fragile. You might have omental wrapping that you literally have to peel off like a toilet paper tube sometimes. Lots of mesenteric fat, right? And you're doing gentle spreading. You, as the assistant, have to have some good traction on there. You can divide that appendix from the cecum. Some people love to do endo loops. Some people still do staples. GIA is mostly um, the typical way to go, right? Endo GIA is big in Switzerland and Europe right now, right? And of course, then you're getting that um, artery divided. You control it first, cut it towards the end. Get that appendix out. You can use a fourth port or you switch cameras and you get it out of the 10 millimeter, which is anteriorly. Keep it in the bag. And again, you're going to send it to pathology. Once that infection is out, then we can really do a good um, irrigation, right? Especially if there's any rupture, you already know you have to be much more aggressive that way. You do a quick look after all this is over to make sure that nothing crazy is left behind, right? So, you know, kind of looking at this whole story, right? Um, and thinking about all we know about appendicitis now, it does seem like his appendix was brewing for several weeks. He had a walled off appendix. That retrocecal component did lock it off. It kept it from becoming severely septic, right? So think about that. Last topic, because it does happen out there. And guess what, everybody? With NOTA, non-operative treatment of appendicitis, I am seeing people develop chronic appendicitis where they have long-term right lower quadrant pain that comes and goes with nausea, with anorexia. When they move their leg, they're doing their own Soaz and Ravsing sign. And most everybody with acute appendicitis is having um, a history of acute appendicitis, which was treated non-operatively. Really interesting, right? This chronic right lower quadrant pain, right? This failure of medical therapy to completely resolve this. When you do a scan, most of them are going to have an abnormal appendix. Again, common sense, right? Lower quadrant pain, think about the appendix, right? So we typically will manage this with adhesionolysis. Write this down. A chronic appendix gets a lot of adhesions around it, right? They'll typically in chronic appendicitis have a normal leukocyte count. CAT scan is not going to really show much, but pathologically in chronic right lower quadrant pain, you get that appendix out, you are going to see pathologically that it is not normal. And chronic right lower quadrant pain, 93% of people get better when you remove their appendix. As I said, just a couple of weeks later, right? Even Gloria Vanderbilt, the mom, couldn't save Anderson Cooper from a very similar appendicitis. And that happened right in the middle of Manhattan, right? So, everybody, what do you need to remember from ASPA tonight? Number one, like Elton John and Anderson Cooper, older patients don't follow the rules, right? The location will give you the symptoms retrocecal, anterior, inferior, right? Don't do surgery if someone has a hostile abdomen. Hydrate, drain, and antibiotics. Omental wrapping around the appendix may make the symptoms disappear temporarily. And in my hot headed opinion, anorexia is a significant warning sign. Be much more aggressive in women of childbearing age. As soon as you have a suspicion, you smell appendicitis, give antibiotics to stop the inflammation. CRP is becoming more important than a white count. Do the simple things that PAs are famous for. Make sure you order NPO. Make sure that they're in a gown. Remember the warning sign. You took notes on this before. Remember the warning sign of 12 hours and 24 hours, right? Use your risk stratification score to say, is it a low, intermediate, or high risk? That's mandatory language in the appendix world right now. Think about that. So remember the song tonight when you're brushing your teeth. No to not, no to not, no to not. Non-operative treatment of appendicitis is a thing, but it's a minority case. Bad things can happen. You will see more of that um, over time. Fantastic. Let me just check the chat for anything interesting there. Yep, robotic liver transplant. Yeah, same data, right? I like it. Don't perforate, right? Before getting a white count. Great comments. I like it, like it, like it. Great. Yeah, Laura's killing it on her general surgery rotation. Fantastic. Everybody, remember, go to the ASPA website. We've got all of our old CME there. If you remember, you don't have to pay for new CME. If you're coming to New Orleans, we've got a great reception plan for you. Check us out on X and Instagram. We allow people to do Instagram takeovers. You can email us about that. And I hope you watch this over and over and over and over and over. There'll be even more interesting stuff on the appendix. There's some new data coming out in the summer. So this may be all new and updated before you know it. So great. All right, everybody. We'll see you next time. Thanks for coming. We'll see you then.
Thank you.
You bet. Be good.
Thank you, Jerry. That was awesome. Everyone have a
Great.
great night.
You bet. See you later.